been approved by the Commission on Cancer and the American College of Surgeons and will be launched during 2015. Thank you very much.
Thank you, Professor Wexner. We next welcome Professor Jun Ji Kim. Professor Kim is a professor of colorectal surgery and director of Minimal Access and Robotic Surgery Center at Seoul St. Mary's Hospital, the Catholic University of Korea. Professor Kim had performed the world's first laparoscopic sphincter saving surgery in 1996. He has achieved excellent results in both the quality of life and survival rates for patients with colorectal cancer. So he's going to give us talk about technical tips for laparoscopic sphincter saving surgery for colorectal cancer. Let's welcome Professor Kim. Technical programs. We will persist against the topics and return back for Professor Kim. The next topic will be presented by Dr. Mariana Berho. Dr. Berho is the director of laboratory medicine in Cleveland Clinic, Florida. He is a well-known oncological surgical pathologist. He had given an excellent speech about the dysplasia in inflammatory bowel disease yesterday. He's going to talk about specimen evaluation and histopathological prognosticators after neoadjuvant therapy in rectal cancer. And let's welcome Professor Berho.
Thank you. Thank you very much for having me back here. So I think that it is fair to say that despite a lot of promising advances in the molecular biology of tumors, TNM still is the most important factor to predict prognosis in patients with colon and rectal cancer. The TNM staging system that was defined many, many years ago is a very powerful predictor of prognosis for both colon and rectal cancer. It has also the benefit that is used worldwide so we can all communicate and understand the situation of a patient, the staging of a patient using this system. Now, the thing with rectal cancer is that we also know that the majority of patients that have advanced rectal cancer will receive neoadjuvant chemoradiation before the surgery. The idea is to decrease the rate of local recurrence, to increase survival, because this has been clearly shown now. I mean, we know that a good tumor response is associated with a decreased number of positive nodes. So how does neoadjuvant chemoradiation improve prognosis? Is it because it decreases the depth of invasion within the rectal wall? Is it because it converts positive nodes into negative nodes? Is it because reducing the tumor size, we have a more higher chance of having a negative circumferential margin? Or is it the fact that decreasing the tumor volume is associated with a better prognosis? And really, most likely, there's a combination of all of these things together that explains the benefits of neoadjuvant chemoradiation. Before we continue, I wanted to make sure that we all understand that the term tumor regression is not the same as tumor downstaging. Tumor regression is the same as tumor downstaging when we have complete pathological response. Because if we have complete pathological response, this means we don't have any more tumor in the specimen, then we will have a T0. But we need to remember that sometimes we have marked tumor regression. Maybe there's a few glands left in the specimen, but there's no tumor downstaging when we compare the clinical staging of the patient. At the same time, sometimes we have a patient that, let's say by ultrasound or MRI, started with a T3. After neoadjuvant chemoradiation, that patient is now a T2. So there has been downstaging, but there still is a lot of tumor. So the question is, what is more important? So you can see an example here. This is an ultrasound, and you can see the tumor that is going into the perirectal soft tissue. After the patient received neoadjuvant chemoradiation and the specimen was processed by us pathologists, we saw that there was only these three malignant glands left. But these three malignant glands are still in the perirectal soft tissue. So there's no downstaging. If the patient started with a T3, it's still a T3. However, there's only 3 left glands. So the question is, what is more important? Having downstaging or having tumor regression? Or maybe they predict prognosis in an independent way. So why is this important? Because when we give a patient neoadjuvant chemoradiation and there is tumor response, we're going to have a divergence between the post-treatment and the pre-treatment. So what is the oncologist going to use to make treatment decisions? So the question we are asking basically here is, what's the power of the TN staging system in patients with rectal cancer that have received neoadjuvant chemoradiation? There's many studies that have tried to answer this question. I mean, at the beginning, this was a little confusing because many different kinds of stages were put together. The type of preoperative treatment was different from one patient to the next, and we pathologists didn't have a standardized way to evaluate tumor regression. So the correlation between the PT and the prognosis is a little controversial still. But what I want to make sure that we understand is that the status of the lymph nodes after neoadjuvant chemoradiation and radical surgery remains the most important pathological factor that predicts prognosis in these patients. And this has been shown in several studies. This one over here with 333 patients, it was shown the overall survival in patients with negative nodes after the treatment was significantly better than when there was positive nodes. This is another study here. I think my laser died. It's another study that was done in the US by the MD Anderson group with so it's a large number of patients, and again, they saw that patients with positive nodes had an increased risk for dying of their disease. This, I thought, was also a very interesting study. This is a study that is coming from Mass General. You can see the arrow here, with almost 400 patients. Some of them had received neoadjuvant and some did not. And they again saw that patients with positive nodes after neoadjuvant chemoradiation had a shorter time to local recurrence and a shorter time to distant metastasis. What I think was very important that was demonstrated in this study is that the presence of lymph node metastasis in patients that receive neoadjuvant chemoradiation, the meaning of that is even worse than in patients that have not. So let me explain this better. In patients that did not receive neoadjuvant chemoradiation, the presence of lymph node metastasis in the specimen has less of a bad impact compared to patients that did receive neoadjuvant chemoradiation and have positive nodes. This is our own study in which we wanted to see, considering that the relationship between the T stage and the prognosis is a little more controversial, we wanted to see if the T stage in these patients can predict the status of the lymph nodes. And you can see clearly that the the deeper the tumor, the higher the incidence of positive nodes. Yeah, I don't know what happened, maybe the batteries. But what I wanted to point out here is that we had 20% of patients had complete pathological response. And you can see that in 2 of those patients, we had positive nodes. So 11% of our patients with complete pathological response still had positive nodes. Now, this is another study in which they show with 178 patients that did receive neoadjuvant chemoradiation, again, that the number of positive nodes, even when there was a complete pathological response, was in the range of 11%. The point that I'm trying to make is that getting a complete pathological response in the rectal wall does not necessarily tell us that that patient doesn't have positive nodes. And this has been, again, shown in many circumstances, and the range of positive nodes after complete pathological response varies significantly. I mean, this is our own study here, and another study that showed a very high percentage of positive nodes, 16.9% from a group in France. You can see that the things that we have in common with this group is that the mean number of dissected nodes was significantly higher than in the cases in which the number of positive nodes with complete pathological response was low. So, what is the impact of a complete pathological response and the depth of invasion in patients that don't have positive nodes? And it seems that in the context of negative nodes, the YPT, so the depth of invasion in the rectal wall, does correlate with prognosis. Now, the other study, and this is a study that is coming from Korea that I thought was very interesting, with more than 400 patients. And what they did is they looked at the patients with T0 to T2 after neoadjuvant chemoradiation. And again, they saw that a significant percentage of these patients had positive nodes. And the positive nodes were correlated with the depth of invasion in the rectum. And you can see patients with complete pathological response, more than 9% of them had positive nodes. Now, the other thing that is something to remember is that neoadjuvant chemoradiation, we know decreases the number of nodes that we're going to find in a mesorectum. So does that matter? Because we know that the number of nodes dissected from specimens in the colon and rectum is associated with prognosis. But the rectum is a little different, particularly after neoadjuvant chemoradiation. So some studies have shown that a decreased number of dissected nodes has no impact on prognosis. Some other ones, like our own study over here, has shown that there is some correlation, and I'll show you exactly what we mean. And we wanted to study the relationship between the number of lymph nodes that we could dissect from these specimens with other parameters that are also modified by preoperative chemoradiation. What we saw as expected is that the deeper the tumor into the rectal wall, the higher the number of nodes dissected. This is usually how it is in colon and rectum. The deeper the tumor, the more nodes we're going to dissect. We also saw that the greater the tumor regression, so the less tumor left, the less number of nodes that we found. We used the Dworak regression system, and you can see that when we had a good pathological response, the number of nodes was significantly less than when there was no response at all. Now, let me show you what we found here. We used both traditional methods of palpation and visualization for a while, and then we used a method to enhance the recovery of lymph nodes. What we saw is that when we started using that method, the number of nodes that we were able to dissect from the specimen significantly increased, and it went from 9.6 to 27.6, so significant amount of numbers. However, when we looked at the number of positive nodes, there was no difference. So we were able to dissect more nodes with this technique, but we did not see any abstention. However, when we looked at the group that did receive chemoradiation, again we saw an increase in the total number of nodes from 5.2 to 20.4. But when we looked at the number of positive nodes, we did see that we found more when we used this enhancing technique. So we suggest that, particularly in patients with neoadjuvant chemoradiation, where the nodes become so small, the use of these techniques may be of help to find actually positive nodes. Now, what about the relationship between tumor regression and prognosis? I think at the beginning it was a little controversial. Now, we all know that the more the regression of a tumor, the better the prognosis. I think it is very important for us pathologists to know how to evaluate tumor regression, the way that we should look at the specimen once the surgeon gives us to us. And we use the different tumor regression grades. I think that it doesn't matter which one you use as far as it is validated within the pathology group. Here we have a specimen in which the regression has been really good. There's just this little area of nodularity very close to the distal margin. When we take our sections from a specimen like this, we need to make sure, because there's just that little area of nodularity, that we submit the entire area, because we don't want to call something complete pathological response only because we didn't examine the entire area. In this particular case, in which the remaining area was so close to the distal margin, we need to make sure that we take the tumor and the distal margin together. There are other cases in which you can see here that the tumor didn't respond very well to the therapy, so you don't need to submit the entire area of tumor. Just make sure that we submit the area that is closest to the circumferential margin of resection. So these are the different types of tumor regression grades. Again, it doesn't matter which one you use. I mean, pathologists, we are infamous for not having good inter- and intra-observer variability when it comes to these types of things. It has been shown, once again, and we had the same experience in our department, is that when you sit down and establish criteria, you can't get a good level of agreement. Obviously, the more categories that you introduce, the poorer the inter-observer variability is going to be. So those tumor regression grades that have only 3-point grades have a better kappa levels of agreement. So what about tumor regression and lymph node status? Which one is more important? Because we said that the lymph node status is the most important prognosticator for patients with rectal cancer after neoadjuvant chemoradiation, and we also said that tumor regression is a good factor to predict prognosis. However, tumor regression is a good prognosticator when the lymph nodes are negative. If the lymph nodes are positive and we have a good pathological response, still is going to be that positivity of the lymph nodes that is going to drive the prognosis of these patients. The other thing I wanted to finish with is to remind us that at least in the United States, the majority of patients with advanced rectal cancer will receive neoadjuvant chemoradiation. And we know that only half of them actually are going to respond to that. So we are exposing patients to toxicity unnecessarily. So it would be important that we find biomarkers that could predict that response to neoadjuvant chemoradiation. So we studied this subject with one of Dr. Wexner's fellows from Israel, and we wanted to look at the expression of apoptotic markers and markers related to tumor progression to see if we can find any kind of relationship. So we used a bunch of apoptotic markers from the extrinsic pathway of apoptosis, And then we used vascular endothelial growth factor that we know promotes tumor progression as well as COX-2. And what we did find is that the only one, and I'm going to go a little faster here, the only one of the apoptotic markers that was associated with good response was one of the APAF1 in the p53 pathway. Instead, both overexpression of COX-2 and vascular endothelial growth factor were associated with poor response. So this is obviously something preliminary. We should have some kind of signature, molecular signature for these kinds of prediction models, but it's a start to tell us that we need this kind of tool to not to expose these patients to unnecessary toxicity. So in conclusion, the reports of rectal cancer specimen in patients that have received neoadjuvant chemo radiation obviously should include the PT and the PN, but we also need to remember that there's other factors that are not present in the TN staging system that are very important. The mesorectal quality, the plate of surgery, the circumferential margin of resection, and the tumor regression rate. So thank you very much for your attention.
Thank you, Professor Berho. We proceed to next talk. This talk will be presented by Professor Francois Lacan. Professor Lacan is now the professor of okay, that's where Professor Kim. I think now everything is ready.
Thank you very much. With my computer, some trouble with the connecting system. Among the MDT, my part is only a surgical part. Today I will talk about typical tips for sphincter saving procedure for very low rectal cancer. For protectomy, we must know the TME. TME is very important, most important part. But we must know the high ligation of the IMA and IMV. Also, we must know the full mobilization of the left column, including splenic fracture. Before my main talk, I want to explain my term, laparoscopic abdominal transanal protosigmoidectomy with colorectal anastomosis obligated as a lateral section. I influenced by Professor Gerald Marx lateral section. That's why I named it here. I don't know which term is better. Everybody knows the TME with colorectal anastomosis, but I think this term, laparoscopic abdominal transanal protosigmoidectomy, is a better term because can you use a term TME for all surgery of mid and low rectal cancer? I think we need not say the term TME because every surgery for mid and low rectal cancer, the TME is must. Before talking about technical tip, we should know the general oncology principle in colorectal cancer. We must make an adequate resection margin, and also, if possible, no-touch isolation technique is better. I think I teach my junior staff and fellow we are not bowel surgeon. For colon cancer surgery, you must be a vascular surgeon. So primary vascular approach is absolutely necessary for non-touch isolation technique. Also, I use the centrifugal dissection of the mesentery for avoiding the manipulation of tumor-bearing segment. Of course, if we keep a function, we must do that. This is my main slide. For laparoscopic colorectal cancer surgery, I strengthened only 3 basic technical tips. I think we surgeons are tissue designers. For making a good design, we need absolutely good exposure. Without good exposure, we can't make good design or any good drawing. For good exposure, we used position change. We used gravity to put away from the small bowel from the dissection field. But sometimes it is not enough. So we can use retraction tool. I usually use the endographic. Sometimes I need an endoscopic retractor. I think for good design, of course, we make a good incision on the mesentery or omentum. But for redundant omentum or mesentery, at least we need a 3-point traction. 2-point traction is not enough for making the board, drawing board. To preserve normal tissue intact, to remove cancer-bearing bowel and mesentery completely, or to make a dry field, not bloody field, we must dissect along the embryological avascular fusion plane. This is all today I want to talk about. Everybody know this? Most important position, supine and head down, but right hip, but no elevate the thigh. It's very important point. I use the pneumopectomy with the Verus needle, and I use the trocar, 5, sometimes 6 trocars. In order to explain my LATA procedure effectively and for your easy understanding, I divide my procedure into 6 steps. But today, I will show you only step 1, 2, and 5. Total refractory excision, already my friend, Dr. Shigeki Yamaguchi, explored, maybe almost the same. That's why because of the time limitation, I passed the TME part. I started this surgery incising the peritoneum, just the basal part of the mesosigmoid. This incision lengthened along the aorta toward the inferior mesenteric artery. You must keep the avascular plane, it means below the mesentery, above the false fascia. It's very important. dissect thoroughly. But during this procedure, you must be very careful not to injure the hypogastric nerve, strengthened here. Up, clip, and dilation, but not very close to aorta. It might be 1 centimeter distal from the aorta.